Here, as we begin talking about heroin and other opioids from understanding to action. So besides recording this session today, if you wouldn't mind keeping your mic muted until such time that we have our Q&A, or Kevin may perhaps open the floor for questions, we'd appreciate it. So without further ado, Kevin, we'd like to hear more about how the Partnership to End Addiction is addressing these issues and what we can do in our community. So I do believe you have screen sharing action. Let's test that out, make sure.
I can always see the chat as they pop up, but Danella, if you see a good question to ask, just please share it as we're going through, and obviously we'll have time for questions at the end as well. Again, my name is Kevin Collins. I'm Director of Family Services for the Partnership to End Addiction, and just greatly appreciate the opportunity to speak with you all today. So just a little bit about the partnership before we begin. We are a national nonprofit. We're based in New York City, but we serve the entire country. And we want to be a place where families can come and find answers to many of the issues related to substance use. We'll talk more about that in a bit, but really opioids is one of the main, if not the main, substance use issue that has affected our nation over the past several years, but especially in the past 5 or 10 years. So this is a presentation we've developed, and it's really designed as a train the trainer presentation. This is a presentation that will be made available to you so that if you want to go out and deliver this presentation yourself, you are more than welcome to do that. And we'll have some information on how you can do that later in the presentation. But even if it's just information you hear today and want to share over the backyard fence, socially distanced, of course, that's something that you can do, or share via email, social media, however you want to do that, that's fine. There's many different ways to share this information. The subtitle of this presentation, From Understanding to Action, is really kind of important. We always want to increase understanding of an issue. Knowing more is always good, but the really important thing is to take action. And what we'll do is we'll talk about the problem, how big is it, talk about the nature of the issue. We'll talk some about opioids, how they affect the brain and body. And then we'll talk more about what's being done and what we can do in our lives and in our communities as well. So I will. So what are heroin and other opioids, and how did we get here? And some of you may have been working in this field for some period of time, and some of this may appear to you to be somewhat basic. This is a presentation that we developed really for a consumer audience, people who may have seen something about opioids on the news. They may, maybe something they're aware, hey, there's this problem out there, but they don't really know a lot about it. So, and hopefully there will be a few things in this presentation that are new to you, that is new information for you. But just as you go through, just thinking about how you could potentially use this presentation to share information with others. And one thing I will share is that there are speakers notes that go along with this presentation. There are videos that go along with this presentation, all of which will be shared with you. But again, that's the package that you would receive. So. Question, what are opioids? This is a definition we use. There's many that are out there, but this is kind of a simple one. They're made from the opium poppy plant or artificially produced to have similar effects. They are depressants. So what you see is the pretty flower there. That's where a lot of this problem starts, is with the poppy plant, where heroin can be produced from. In the middle, you see a pharmaceutical lab. Again, pharmaceuticals, that's another place where a lot of this problem has come from, as people, work to create medicines which are designed to help and to heal, but have also caused a lot of damage in our country over the last several years. On the right-hand side, that is from a few years ago, but it's a fentanyl lab from up in Canada. There's a reason why they're wearing hazmat suits, is because a lot of dangerous chemicals go into the production of opioids, fentanyl in this case, but also many other drugs. So just you kind of see the three sides of the issue there. Across the bottom, you see opioids in various forms. Some may be familiar, some may be less so. what we try to get a point with across at this point is that they're all very similar at the molecular level. They all have their own properties, of course, but they're all very similar and they have similar effects upon the body as well. So the risks of opioids, as we mentioned earlier, they are depressants and they can be dangerous just unto themselves when misused, but they become even more dangerous when they're consumed with other substances. So for example, alcohol and sedatives can slow the body down. So a depressant really kind of slows things down. When you keep slowing things down, that can result in an overdose and potentially death. When you add opioids to a stimulant such as methamphetamine or cocaine, basically, it's like putting a car in drive and reverse at the same time. It's not good for a car. It's also not good for a human being. So those are some ways in which they get risky and dangerous. The other way to think about how opioids can be dangerous is when they're combined with other substances. And some substances which can be added to opioids are used to add bulk or to cut heroin. So some relatively pure heroin is brought into the country. People can add other substances to it as they are selling. Sometimes that's called being stepped on. So at each step in the distribution process, people may add additional substances to it until you get to the point where the person who is selling opioids on the street really does not know what they're selling. And, we may think about heroin typically for this, but now, with the availability of pill presses that people can get, even there's counterfeit hydrocodone, Oxycontin, other drugs that are out there that can also contain substances that you're not aware of. I sometimes when I'm describing this to an audience, I'll use the metaphor of meatloaf. You start out with a pound of meatloaf and you add breadcrumbs, you add bread, you add spices, you add a bunch of other stuff to it, and all of a sudden you have 2 pounds of meatloaf from 1 pound of meat. Same concept here. Other substances that can be added to opioids, such as illicit fentanyl, are going to change the potency. And we'll talk more about fentanyl in a bit. The bottom line is that a person who is misusing opioids does not know what they're going to get. So the Centers for Disease Control and Prevention have described 3 waves of the opioid epidemic. So the first was the purple line here. So some commonly prescribed opioids such as methadone, for example, some others, hydrocodone, Oxycontin, some of the names that you're familiar with. And what we saw in the 90s was a very slow but steady increase in the deaths and overdose deaths per 100,000. This purple line kept going up and up and up. And some states reacted to this faster than others, but finally around 2010, 2011, the federal government started taking action against this and said, hey, there's something we need to do to respond to this. So they started restricting availability of some of these commonly prescribed opioids, started making them more difficult to obtain. What happened at the same time is that you see this orange line of heroin starts to go up and up. And the heroin that was coming into the United States had a higher level of purity, so you started to see deaths from that as people made a transition from using Oxycontin, hydrocodone, et cetera. Then sometimes they were not familiar with the dosage, sometimes it was much more powerful, and you started to see deaths from heroin rise. What happened around 2013 is you start to see fentanyl, tramadol, other synthetic opioids start to come into the United States. Sometimes they're mixed with heroin, sometimes they're being sold by themselves, and you're seeing an increasing number of drugs which fentanyl are being added to. And that is what is really from about 2015 on was driving the number of deaths that people were seeing. So unfortunately, there may be a 4th wave to the opioid epidemic as well. What you're starting to see is some stimulants, some other drugs as well, the fentanyl being added to that, and you're starting to see deaths as a result of that as well. And as I sometimes say, if you don't believe the DEA that this came from, you might believe Rolling Stone, because Rolling Stone is seeing the same thing as well. So here's a comparison of lethal doses of heroin and fentanyl. On the left-hand side is heroin. That is a lethal dose. Sorry, just 1 second, trying to move the little picture around here. Lethal dose of heroin, about 30 milligrams. That's enough to kill an average adult-sized male. On the right-hand side, just those few grains that you see of fentanyl is enough to be lethal. So sometimes I use the analogy of a Splenda packet. If you think about a Splenda packet or an Equal packet, if you shake that, if that was fentanyl, that'd be about 100 lethal doses contained in that packet. So it is relatively inexpensive. It's very easy to bring into the United States. It's very easy to smuggle, and it becomes a huge risk to those who are using it. Becomes very difficult to interdict, which is part of the reason why you're seeing so much fentanyl coming into the United States. And this is part of a larger trend. I've heard the phrase moving from farming to farming, farming with an F to farming with a PH. Is farming, there's a lot of production costs. There's a lot of, you have to pay the farmers, you have to ship it across the country, across the world, frankly. With fentanyl and other analogs that you see, such as carfentanil, people need to move a few molecules around, and all of a sudden you have a substance that can be sold and that people will seek out and that can be very dangerous to people. So we get into the question of why people misuse opioids. There's no single reason for everyone. Everyone has their own path, everyone has their own journey, but we'll talk about some of the main reasons, some of the buckets of reasons why people might misuse opioids. And again, as I kind of get to these breaks and sections, if anybody does have any questions, please put them in the chat. Really welcome that as we go through. So that's a question, why do people start misusing opioids? There's a number of reasons. Somebody may have been prescribed opioids for pain, begin to misuse the medication for reasons other than pain. So you have someone who may require surgery or oral surgery, for example. They get prescribed some hydrocodone, for example, or oxycodone. And they start taking those medications, and all of a sudden they're not feeling the stress that they felt previously. They start to get a good feeling from that, and they say, I want more of this good feeling. So they begin to take that. Someone may develop a tolerance for pain pills, someone who may have chronic pain that they're prescribed, and begin to increase the dose on their own. They may also snort or use a needle to increase the effect. And when you think about pills, the way the pills are designed, they're designed to break down through the digestive tract. They're designed to break down over a period of time in the body, especially sometimes you'll see extended released medications. What happens is when somebody crushes those pills or snorts them, the amount of opioids that are designed to be received by the body over 8 hours can be delivered in 8 seconds. So again, you start to see that. For some people, it's the next drug on the table, is a reason why they use opioids. Someone may be using alcohol, marijuana, cocaine, other drugs, and they may be coping with emotional stress or pain. They may be sensation seeking, and maybe just something that they're seeking to do. They're offered opioids, and opioids are the substance that really clicks with them. That is a reason for them to continue to use that. Some use opioids to counter effect another substance. So again, we talked about methamphetamine, cocaine as kind of stimulants, uppers. And basically what somebody might take opioids to basically counteract that effect or to try to balance themselves out. What they're really doing is putting themselves at great risk. And for younger people especially, I've got 2 daughters. They're both older teens now, 17 and 19. But if my daughters come home at the end of the night and they've been drinking, I can smell it on their breath. If they've come home and they've been smoking pot, I can smell it on their clothes. It's a little bit more difficult to detect opioids, and we'll talk about how you can do that later in the presentation. But again, they're also much easier to hide, difficult for a parent or a caregiver to detect. So again, that may be another reason why people turn to pills instead of some of the other substances they may have available to them. So next, we get to the question of why do people keep misusing opioids? Essentially, what happens is the body adapts to opioids. I've heard people who are in recovery talk about, the first time they used opioids was the best feeling they ever had. It was the first time in their life that they felt right. It could be a feeling of euphoria. As the body adapts to opioids, they're no longer feeling that feeling of euphoria that they initially had. So during that, as the body adapts, what happens if somebody stops using is that they may experience withdrawal. And withdrawal basically means taking something away. It means if you take opioids away from a body that has become accustomed to it, they start to experience classic withdrawal. So for the first 24 hours, there may be muscle aches, there may be anxiety, teary eyes, sweating, inability to sleep, yawning. And I talked about how opioids are a depressant. They essentially slow everything down in the body. What happens is there are no longer opioids in the body, things start to speed back up. So one of the things that happens with opioids is it slows down the digestive tract. So if you take opioids away, all of a sudden people feel diarrhea. They could feel abdominal cramping, goosebumps, nausea and vomiting, dilated pupils, meaning the black part of the eye gets really big. When people are using opioids, the black part of the eye gets really small, so they may have blurry vision as a result of that. Rapid heartbeat, high blood pressure. These are all some of the things, these negative feelings somebody may have because they stopped using. So there's this thing that they get some level of satisfaction out, and then you take that away and they start to feel horrible. Nobody wants to feel horrible if they can avoid it. Relapse is another time which is especially risky. If somebody starts using opioids after they've stopped using for some period of time, and that could be because they've been incarcerated, it could be because they're in treatment, it could be because they just don't have access for some reason, that is especially concerning, because if somebody goes back to using the same level that they did previously, they're putting themselves at risk of an overdose. And again, even if somebody says, I'm going to be smart, I'm not going to use as much because, I really know how risky this can be. They really don't know what they're going to get, going back to the slide we talked about previously. So next we're going to see a video from a young man named Nacho. He's going to talk about his experience with withdrawal. He's in recovery now. He's doing well, but again, this is his experience.
I had gone through tons of withdrawals, times where, you're sick. It feels like 1,000 times worse than the flu. You're sweaty. You're trying to get through anything. I would walk into class, in these withdrawals, and I would go through this horrible week, and, never gonna do this again. And 2 days later, I'd already made it through the acute withdrawals, but I was using again, and knowing full well that I'm gonna have to go through that again at some point. I wish I knew really what these prescription pills were. These are all synthetic forms of heroin.
So what does an opioid overdose look like? Again, there's no one size fits all here, but here are some of the key things to look for. Is the pinpoint pupils are pretty much always present. And then again, that means the pupil, the black part of the eye, is very small. Somebody may be awake but unable to talk. The fingernails and lips turn blue or purplish brown. Skin tone may change color, and the reason for that is that oxygen is not getting out to the extremities of the body. So that's the reason why the tips of the fingers become deoxygenated, and that's the reason why you see the change in color. The breathing could be very slow, shallow, erratic, or is stopped. There could be a pulse could be slow or erratic. There could be choking sounds, could sound like snoring. Sometimes that's called the death rattle. And someone may be unresponsive to outside stimulus. We'll talk more about naloxone and Narcan later in the presentation, but one thing I always want to make clear whenever we talk about naloxone or Narcan, which can reverse an overdose, which can be applied if you see that someone has overdosed. It's all very important, but it's also important to call 911. There's a few reasons for that. The typical kit that people have of Narcan or naloxone, and they're really the same drug, it's just Narcan is the brand name, is there's typically 2 doses in there. And someone may lapse back into an overdose. Basically, an overdose has a half-life, so somebody may, again, even if you revive someone, they may lapse back into an overdose. Especially if someone has overdosed from fentanyl, it may require more than 2 doses of Narcan or naloxone to revive someone. And also, you don't know what other drugs someone may have taken. And finally, there's an important piece called rescue breathing. which is an important part of this, to not only, again, if someone has been deprived of oxygen, of trying to get them breathing again is really important. And again, bringing in medical professionals, bringing in EMTs is extremely important to try to save someone's life. So next we're going to see a video about a young man named Aaron, guy on the left there. Young man, and he had had some involvement with substance use, but you know, overall good kid. He went to a party at a friend's house, and there were some pills there, and he took some of the pills and he overdosed. And the kid who was hosting the party went to his own mom and said, "Mom, Aaron overdosed. What do we do?" The mom did not want to call the police. This was several years ago at this point. And over the course of the next 5 hours, they tried a lot of things to try to revive Aaron. They tried giving him coffee. They tried putting him in the shower. They tried putting ice on him, and none of these things revived him. And this is the rest of the story.
He was full of energy.
Full of energy, and loved to wrestle and goof around and
Play. He was very lighthearted, fun child.
I didn't know what he was taking. It was 220. And some of the addiction is so strong. These kids don't know how to handle it.
Ready to get in the chair? It's a fine mess you got us into, isn't it?
We'd much rather have Aaron like this than dead. And a lot of parents don't have that luxury. We can kiss our son at night.
What a life, huh? Dad shave you in the end?
You like shaving? 1 yes, 2 no. No.
The worst consequence is death. Other consequences are, like Aaron, trapped in your own body, alive, but still unable to communicate the way that you would hope that you could. You also lose all of your hopes and dreams and things that you wanted to accomplish in your life.
You can help.
Did you ever think anything bad would happen taking prescription pills, Aaron? 1 for yes, 2 for no. No.
Help save kids from prescription drug abuse. Secure your medications and talk with your kids. Visit drugfree.org.
So as we kind of have reviewed the issue, and again, there's a lot more to talk about with all of this issue. You know, this could be an 8-hour presentation, but what we try to do again is to keep this to roughly an hour. Just, is there any questions? If you want to put them in the chat, or if you want to unmute, that would be fine before we move on to the piece about what individuals and communities can do. Okay, not seeing anything. All right. So I want to talk about what's happening. So kind of the model we use here is talk about what's happening and then what more can be done. So when this problem kind of was first really recognized at the national level, and there's a lot more, you know, and again, I recognize New England, various parts of the country had been hit really hard by opioid abuse prior to 2015. But it was around 2014, 2015 when the federal government really started focusing on this issue. There was a recognition of the need for prescriber education. A lot of doctors, dentists, others had come up at a time when they were trying to do everything they could to relieve pain. It was referred to as the sixth vital sign. Hospitals were judged upon their ability to reduce pain. I remember an old ER episode where, you know, Doug Ross, played by George Clooney, was the hero. Because he found a way that you know, I think it was a 12-year-old could control his own morphine drip. And I just share that story because it was kind of the thing at the time, driven a lot by the pharmaceutical industry, to say, you know, how do we get as much medication out there as possible to relieve pain? So around 2014, 2015, there was a push in the other direction to say, how can we, you know, prescribe appropriately? And a lot of medical professionals said, you know, and I really didn't get a whole lot of training on this. I also didn't get a lot of training on substance use either, to be able to identify if someone has a substance use disorder or to be able to get them help. So some training started to occur since 2015. A lot of educational courses have been required. Federal health officials have been required to be trained as well, those who work for the VA, other providers as well. One of the things we're really looking at that needs to be done is to make this standard across the country. So making training in addiction and pain management standard practice for both new and existing doctors. And a lot of this is being done. I was doing some research prior to this presentation. Anne Arundel Hospital in Maryland, they implemented some of these practices, and there was a 38% reduction in opioid prescribing. So again, a lot of this is moving in the right direction. The other is that it was a stat that really just jumped out at me, was that 1% of 1% of prescribers prescribe about 50% of the opioids that are out there. So again, educating all doctors is really important, but focusing on those who are, most outside the norm is really key. So what we're seeing is that this is starting to have an effect. So the long-term there, narcotic analgesic dispense volumes and morphine milligram equivalents, that basically means the amount of opioids that is out there. And we see from 1992 to around 2011, that number went up and up and up. What we start to see after that is that that number starts to move in the other direction. And to 2018, the most recent data that we have is that we start to see the number go down and then accelerate. We're also starting to see this show up, what I would say, downstream. So this is from Monitoring the Future, which is a study which has been done by the University of Michigan since 1973, asking 8th, 10th, and 12th graders in the United States a whole battery of questions about substance use. And what we hear from 12th graders is in 2010, over half, about 54%, said that Vicodin, Oxycontin, Percocet are fairly easy or very easy to get. By 2018, that number had dropped to around 33%. So again, 33% still too high. Again, if you compare the United States to other countries around the world, we consume a lion's share. I think last number I remember is around 95% of all the opioids in the world. So we still got a lot of improvement to make, a lot of room to go. But again, we're starting to see this move in the right direction. I think I just did see a question in chat, so I'll try to respond to that. Okay, just a reminder about recording. Super, thanks. So medication-assisted treatment. Some of you may be familiar with supporting recovery from a substance use disorder. There are other medications. Some of you may be familiar with methadone. There's buprenorphine, Suboxone, Sublocade. There's a number of them that are out there, and they all work a little bit differently. They can reduce suffering from withdrawal, cravings for opioids, and help a person who is seeking recovery be in recovery. Some of these medications can be delivered in doctor's offices. It's not a silver bullet. There's a lot of other work that needs to be done at the same time, but they can help as well. So there is an ebook that we have developed for parents and caregivers of teens and young adults who have a substance use disorder, to be able to provide support to them so that they can better understand. So to the extent that they are participating in the treatment decisions for their child, that they can help inform that, and they can come from a position of knowledge of being really an effective consumer. So it's an opportunity to have that discussion. And what we're seeing over a period of time is, again, opioids are dropping while medication-assisted treatment increases are going up. Another piece, and this kind of harkens back to was talking about with prescriber education, are things called prescription drug monitoring programs. They're shortened as PDMPs. Essentially, they're large databases that tracks who is seeking opioids, who is trying to fill prescriptions for opioids, and then who is prescribing them, to really try to identify outliers. So is there a prescriber who is just prescribing a lot of opioids, kind of unrelated to their peers, or is there a person who is what they call doctor shopping? So pill mills is kind of the slang for a doctor who's prescribing a lot of pills. Doctor shopping is a person who's going from doctor to doctor trying to get prescriptions for opioids. We start to see that, and what PDMPs are able to do is they're able to find the outliers there. Pretty much all states have the legislation to authorize the creation and operation of a PDMP, but the more work to be done here is to support efforts to share information between states. So that if you're in, I'm in upstate New York, for example, so that if we can share information with Pennsylvania, so people don't just cross the border to try to get the prescription filled. Encouraging prescribers to use the existing programs. Some states do require people to use a PDMP. New York State went to a program, I believe in the beginning of 2019, where all prescriptions had to be electronic. It was no longer a doctor scratching out a prescription on a pad. Everything was electronic, and you started to see the number of opioid prescriptions drop pretty precipitously after that. And then finally, and this is a point I'll come back to, is fully funding existing programs. Some states, especially at the height of the opioid crisis, we're kind of back there now, unfortunately, put in legislation for a PDMP, but then never really fully funded it or required doctors and other prescribers to use it. Obviously, there's, with COVID, there's a lot of challenges our country faces trying to get the economy up and running again. But even though, the federal government is starting to spend a lot of money, there's going to be states and cities and counties who may be struggling for revenue, and they may have to make a decision where to cut. And as people who are concerned about this issue, is just being effective advocates is really important to say of the places you can cut. We don't want to go back to the problems we had previously around opioids. So just trying to ensure that the funding for programs that really fight against the opioid crisis continue and don't go along the wayside. Good Samaritan laws, we'll talk a little bit more about this later, is that in a best case scenario, there's 3 people using opioids together. One person overdoses, the other 2 dump their friend in an emergency room and just drive off. Then the emergency room tries to do the best that they can with them. Worst case scenario, the other 2 people just walk away, leave the third person to die. What Good Samaritan laws do is that they do provide legal immunity to an individual if they're acting to save the life of another person. That's the idea behind it. And what's important is not just for the public to know about this. The Good Samaritan laws only really work if the public is aware of it. So one thing that you see in upstate New York is our state agency actually has paid for billboards. There's television advertising, letting people know about the availability of these laws, that they can utilize these laws and not have to worry about arrest or prosecution if they're acting to save the life of another person. The other piece of this, though, is that everyone needs to be kind of on the same sheet of music. So, so the prosecutor, law enforcement, et cetera, all needs to be saying we want not just the letter of the law, but the spirit of the law as well. I was in a city in the Midwest where delivering this presentation, someone said, yes, well, we've got a Good Samaritan law, but people are still getting arrested because if they flush the drugs from the time they call 911 to the time that law enforcement and EMTs show up, then they can be arrested for destroying evidence. That's not what we want to be doing here. We want Good Samaritan laws to be really something that the community embraces to save lives. California's Good Samaritan law, there's a lot on the screen here, but I'll just kind of shorten it. It does have a Good Samaritan law acting to save the life of another person. One thing that varies from state to state is whether people are protected from violations of parole or probation, and that is not the case for California's law. Some state laws specifically say even if a person is on parole or probation, it would not be treated as a violation of parole or probation if they are acting to save the life of another person. So they are covered by the Good Samaritan law. I'm not an attorney, I'm not a California attorney, but my best understanding of this is that that protection is not extended in Good Samaritan in California. So that may be something to look at in terms of providing an advocacy step that could be taken in California. Naloxone, mentioned it earlier, but it's important to talk about more. Can save the life of a person experiencing an overdose. Again, in most places in the country, can be purchased without an individual prescription. There's other ways, and we'll talk more about it in a bit, that people can take action to get naloxone at reduced costs or free. But again, this is another place where, you know, we really encourage people who, if you are the loved one of a person who's using opioids, get a kit, get trained to use it. And then again, the advocating for affordable availability. What happened around 2015, 2016, 2017 is there was a recognition there was an opioid crisis. A lot of people went out wanting to get naloxone and Narcan. The price skyrocketed. The federal government stepped in and was able to subsidize the cost of availability of Narcan and naloxone, so it became more affordable for people. But again, you know, I've been working for the partnership for over 20 years. I was, you know, around during the whole methamphetamine crisis, and what I saw happen is, you know, once houses stopped blowing up, it disappeared from the news, and there was still a problem there. There was still an issue that needed to be addressed, but it just was no longer getting the public attention it had previously. And I have that concern about the opioid crisis, is that once it's no longer getting the attention that it had previously due to competing news stories, that some of the funding may go away that has been so important to help people. I just see a little chat popped up. How important is the disease concept getting pushback on Limpton? I'll just read the question straight and not try to scan it. So the question is, how established is the disease concept of opiate addiction? I'm getting some pushback on LinkedIn by those who are adamant that when people have their needs met, they don't misuse drugs of any kind, particularly opiates. That's not my experience and appears to be a rejection of the disease concept. How pervasive is this pushback? And I may be misunderstanding the question a little bit, but I'll just try to answer to the best that I can. Is that you know, we view substance use disorder as a health issue, and that it needs to be treated as a health issue. And basically, if it is interfering with the quality of life, the ability to take care of your responsibilities, taking care of basically enjoying life in a really important way, that is when it does become a health issue. And there's a few concerns here. First is for use by young people. One thing we know is that about 90% of substance use disorders start before the age of 21. We know that a person who starts using at the age of 15 is, I believe, 5 times as likely, it's in the other presentation we have, 5 times as likely to develop a substance use disorder as somebody who starts using at 21. So particularly use by young people is dangerous. Even for older people, if I'm understanding the question here, the problem with this disease, this health issue, substance use disorder, whatever you want to call it, is that people may not see themselves succumbing to the issue. So people may be using and saying, because it's not causing problems elsewhere in my life, I'm fine. People may not know when they're crossing that line. So a big question is, whether it's a young person, you're the parent caregiver trying to take care of, concerned about your child, or for an adult who you care about, maybe a spouse, friend, is what is leading someone to use in the first place? What is the problem that they're trying to solve with substances? And getting to those underlying issues, they may be mental health issues, they may be stressors that they're facing, can really help address, may be able to help get to the root of the issue and to address that. So I'm not sure how well I answer the question. The bottom line is we definitely view this as a health issue. Some people find the disease model helpful. Some people find it a challenge. The bottom line is we want people to live the best, healthiest life possible. And what we know is that substances can get in the way of that. So hope I answered the question okay. If you want to follow up, please feel free to do so. Okay. So now we get into kind of what you can do. And this is especially when delivering the presentation to families, or you never know when there's parents in the audience, is protecting your family. This is a stat I was trying to recall from memory, is that a person who starts drinking using other substances before the age of 15, 5 times likely to develop a substance use disorder as a person who starts at 21. I try not to read my slides, but this is one that merits reading because it's really important. that parents recognize that this isn't just a rite of passage, that substance use at a young age can lead a person to develop a substance use disorder later in life. And, the likelihood of substance use dependence dropping by about 4 to 5% for each year that initiation is delayed. So for me, if I look at my daughters, for someone else looks at their, 11, 12-year-old and say, I don't think that they're going to get to 21 without ever trying something, the lesson later that they use has a huge impact to the likelihood of them developing a substance use disorder. There's a lot of other factors, ACEs, adverse childhood experiences, stressors, genetics, a lot of other things that play into it. But again, a factor that there is some control over is delaying that first use. And abstinence until the age of 21 can be very much the ideal, but the more that's can be delayed is very important. The other thing to recognize, and I was kind of touching on this in the answer to the other question, was that self-medication can start with substances and lead to opioids. So, a parent looks at their, son or daughter, they come home, they think they've been drinking, and kind of say, okay, I'm going to let it pass. I drank at their age, I turned out fine, etc. You don't know if there's something else that they are dealing with in their life. Are they dealing with bullying? Are they dealing with stress at school? Are they dealing with some other issue that they're trying to self-medicate? Because there's the risk that they will continue to use until they develop a severe substance use disorder, and that becomes something that I wouldn't want any family to have to go through. We'll talk about this a little bit later in the presentation, but we have a volunteer program for parent coaches who are peer parent support for parents. It's delivered over the phone, but I've worked with hundreds of parents through this program, a significant number of whom have lost children. Others have kids who are in recovery, but when they think back to that time when their child was using, people have, gone bankrupt. People have, their marriages have fallen apart, all because of this. So this is something that I really wouldn't wish on my worst enemy. So, I don't mean to be too strident in this, but when you hear a person, when you hear a parent say, "Oh gosh, this opioid crisis, we got to do something about it," and they're very, charging the ramparts about that, but then they're buying their kid alcohol because they want them to drink at home, there seems to be a disconnect there. So anyway. How do you do that? By talking, using the power of your voice. Is what we know is that kids who learn about the risks of substances at home are a lot less likely to use than those who don't. So having those conversations, even if they're imperfect, even if it seems like your kid is tuning you out, they are really important because your child knows that this is an issue that's important to you. It's something that they are that you're willing to talk about. It may make it more likely that they're willing to talk to you. You want to offer advice and guidance. We've got another presentation where we talk more about some ideas from motivational interviewing. But again, this whole idea of saying, hey, I have an idea, would you like to hear it? And there's something that's important to me, would you like to talk about it? Inviting your child into a conversation. Once they've accepted that invitation, then they're committed to kind of keeping up their part of the discussion as well. Showing concern rather than anger. If your child is breaking the rules for your household, and one of your rules for your household is that they not use substances, then you may be angry about that. You may feel disrespected. But that's kind of underneath all that is you love your child. I love my wife and kids more than anything else in the world. I don't want anything bad to happen to them. And that's at the heart of the reason why you don't want them to use. Asking open-ended questions. If you ask a closed-ended question, which only has a yes or no or has a very direct answer, has its place, can be fine at times, but it's less likely to keep a conversation going. Even if you think about a volley in tennis of the ball going back and forth, keeping that conversation going, making an ongoing conversation. It's not just the one lecture you give them when they turn 13 about drugs. It's an ongoing conversation you have with them about everything that's going on in their life. And the more you leave it open-ended to them, the better. Trying to understand your teen's perspective is really important. We tend to kind of gloss over some of the tough things that happen during the teenage years and think of them as the best years of their life. I know for my kids, for a lot of other kids, especially going through past year plus with the pandemic, has been extremely difficult. So the more you can try to understand their perspective, that can be really important. And you can learn more about how to communicate with your kids at drugfree.org. The bottom line is to keep talking no matter what. You may be frustrated, you may be upset, you may just, I just don't want to do this anymore. I don't want to keep trying. I feel like I'm banging my head against the wall trying to talk to my kid. Encourage you to do is take a walk around the block and another walk around the block until you have calmed down. You're in a position where you feel like you can have a good conversation. Part of the reason why the partnership focuses on families is because families are there before there's a problem, during the problem, and after the problem. There's a lot of good people who may come in and out of your child's life during the progress of their substance use. You're the one who's going to be there no matter what. You're the one who's going to be there for them no matter what. I think there might have been a question up here, so I just want to. Yeah, just recognizing that. So the question is, wouldn't focus on addressing stress, chaos, and lack of support in childhood help the younger generation? Of just, and exactly, but taking the time to say, hey, what is most stressful to you? The chaos may not be an issue in their life, or it may be, or it's like being able to say, asking that open-ended question is like, what's hard for you? What is the thing that, if you have a hard time going to sleep, what's the thing that kind of goes over your head over and over before you're trying to go to sleep? What makes you angry? What makes you upset? What makes you happy? These are the kind of open-ended questions that can really lead to a real constructive conversation with your child. And once they know that they can have these good conversations with you, they're more likely to talk to you about everything, including substances. The less likely they are to try to turn to substances to try to, again, self-medicate. So if your child is injured, let's say they get hurt, let's say they twist their knee playing soccer, whatever, asking about alternatives. So your physician may still prescribe an opioid. And I've got a lot of respect for physicians, other prescribers, but just there's nothing wrong with asking a question if that opioid is absolutely necessary. You want to understand these risks. You want to do some research into alternatives. Acknowledging that some pain is okay, telling us that we need to take care of ourselves, maybe slow down. And the Centers for Disease Control have developed a guide to non-opioid treatments. And again, this is an idea that we're trying to get out more broadly to people. Protecting your family. If your child is prescribed an opioid and you feel that this is the right thing for them, you want to recognize that a lot of problems can come from prescription medical misuse. If your teen is prescribed a medicine, this is not a time to test their maturity and responsibility. You want to be controlling the medication. You want to monitor dosages. Again, going back to the last slide, asking if something other than opioids can be prescribed. And again, tracking how many pills are in each of your prescription bottles or pill packets, making sure that they're not taking more than they should, or taking them to share with others as well. And this is also true. Keeping track of refills is also important. It may not be your child. You may have an elderly relative who has been prescribed a lot of opioids or other substances. You want to be able to see, hey, you may look at your child and think they would never take grandma's medication, but can you say the same for every child that they may be in contact with? Every child who comes into your home, and maybe not. So again, this is a real reason to be kind of keeping track of those opioids, making sure that they're not being misused. Looking for signs of use, constriction of the pupils. They could be for a few hours, up to a day, depending on which substance. There could be shallow breathing or signs of disorientation. Someone may drift in and out of consciousness. Sometimes that's called nodding off. There could be emotional or physical signs of use, behavioral changes, which could be positive or negative. They could all of a sudden seem to be really up. Everything seems to be going okay for them. And it could be like a real abrupt change. So really looking for those abrupt changes is important. What has happened that is leading to this behavioral change? If they're wearing long sleeves at a time when it's not appropriate for the weather, that could mean that they're hiding track marks. Missing or burnt spoons or foil may indicate that they're using them for substance use. If there's money or valuables that have gone missing in a busy household, sometimes stuff just goes missing, I well know. But the bottom line here is to really kind of trust your instincts. If something doesn't feel right, there's probably something that isn't right. It may not be substances, it may be something completely different. But again, what we encourage parents to do is really trust their instincts and learn more at drugfree.org/heroin. So the next part that we get to, and I want to be sure to Just looking at the time, want to be sure to leave enough time for questions, is finding answers. So you can find answers at drugfree.org. That is our website. We want to be the place where families can find answers. At drugfree.org/heroin. We've got a lot of content there that people can go to and find. We've got some specific resources that I mentioned earlier, the medication-assisted treatment one, but we've also got guides on co-occurring disorders when there's both a mental health issue and a substance use issue, which is about 50% of cases. Got information on pregnancy and opioids, and also naloxone as well, are just some of the resources we have. Some of the direct family services that I'm proud to be part of the team that works on this. We've got our helpline. And our helpline is not a crisis line, but we have bilingual, speaking both English and Spanish specialists who provide support, guidance, and resources. People can schedule a phone call. People can communicate immediately by text, by Facebook Messenger, by email. They're there to answer whatever questions families have about substance use. So it could be everything from my kid's turning 12. I know I need to have the drug talk, but I'm not sure what to say. To a parent of a child, air quotes here, child of any age we help, and the child is 52. And they may have been struggling with substances for decades. And a parent, wants to say, hey, we're getting older. How do we help our child? We mentioned the website. We have Help and Hope by Text. We'll talk more about that in a moment. We have an e-learning course that people can sign up for. There's lessons to help strengthen parenting skills, offer tools and strategies. Peer parent coaching, we'll talk more about that in a moment. And then we've got an online support community, we have 4 meetings a week, all on Zoom, all online, where people can participate in these programs. Help and Hope by Text I mentioned earlier. Basically, you can text JOIN to 55753. If you do that, you'll be asked to complete a brief survey. Based upon the results of that survey/assessment, you'll get messages which are customized for you. Your need state, what you're looking for, the kind of information to be most helpful to you. Oh, I'm sorry. The next brief video I want to show you is about our helpline.
At the Parent Helpline, we assist parents who have a son or daughter that's struggling with substance use issues, and we're able to speak to our parents in an open and positive way. While we're certainly not a treatment center, we certainly are able to, speak to you and give you the options that you would have available to you for your particular circumstance, for your particular family. When we're talking about an action plan, we're understanding that no 2 families are the same. So we get the fact that, some families have their child living in the home. Some parents are struggling with, do I kick my kid out tonight? This is the first time I'm hearing about it. Or some parents, have had this be a chronic issue. This has been going on for a while. What am I gonna do? How do I break and interrupt this cycle where my child continues to use and is just not understanding? And so when we're developing these action plans, we're looking at treatment options. We're looking at ways of how you're gonna approach conversations. We're looking at, sometimes we'll even talk about where you might have that conversation, what that conversation might look like. Sometimes we'll have parents giving us some barriers, and we're trying to figure out with the parent how we're breaking down those barriers. We at the helpline are also looking to give that parent support. What does that look like for you? Who's your support system? Because this is an exhausting process, and we want to make sure that you have someone on your side as well. We understand that, you're the most important person in your child's life, and if they don't have you fighting for them, then who will fight for them? We're not a crisis line. However, we understand that this moment for you, that you can be in an emotional crisis, and we listen to you, because there's so many parents who reach our helpline and they feel like no one has been able to listen. And it's so important, and it's almost magical when our parents tell us, you heard me. This is the first time I felt heard. That's really what we hope for at our helpline, for our parents to feel heard, understood, supported, and that they were treated with respect and have been able to really know that it isn't their fault and that we're here for them.
So I mentioned this earlier, parent coaching. We have extraordinary volunteer parent coaches who all have lived experience. All have been the parent or caregiver or somewhere in the parental role for a person with substance use disorder. And now they all want to help others. So all of our coaching happens over the phone. It is accessed via the helpline, so someone can contact the helpline, say, and it is determined by the helpline specialist if a person would be a good fit for parent coaching, and if it is offered to them. Again, it's just been a great experience for both the person receiving the parent coaching, but a lot of the parent coaches themselves who are volunteers have said about how powerful that is for them, is the ability to give back to others. So the last couple slides I have here is about localizing your presentation. So when you think about some resources in your community on treatment, prevention, community involvement, advocacy, this is a presentation that you can, again, really localize, add your own logo, add your own information. You can shorten it, lengthen it, depend upon the needs of your audience. You may have an opioid presentation you're delivering already. Take the slides you like most from the ones you have. Add the ones from this presentation, make a super presentation. So just whatever is going to work best for you. I did go through, I am, again, not a Californian, but there are some resources from the state of California. I know some of the URLs here are a little bit long, but if you just look for California Directory for Substance Use Disorder Services, you can click through and find a lot of great information there. If you're looking to add some more California-specific statistics to your presentation, including more localized, there's a county dashboard there. So if you want to really focus on your county, you can add some information there that can be really helpful. Sorry, just trying to navigate over here. And finally, there's information on naloxone distribution, the California Naloxone Distribution Project. So again, there's a lot of great information there where people can apply for free naloxone, apply for free naloxone, and also learn more about the program, about ways in which they can get a hold of that. So that is the presentation. I just want to open it up to any questions or comments anyone has. If you want to unmute, that's certainly fine if you prefer to do it in the chat. Great.
Wow, Kevin, this is Donnella here. That was phenomenal. We've done some other trainings in the past, but your training today caused me to want to go look for that Vicodin prescription that someone in the household got last year for a knee surgery, because I don't know where it is right now. Yeah. So thank you. That was a good prompt for me today.
Yeah, I'll share. I was kind of in a similar boat. Almost a 15 years ago, I had some back pain, and as was typical at that point, now they do the 5-day prescription. They make sure that it's a limited amount that you're bringing into the home. At that point, I was handled 30 milligram, I think, at that point, hydrocodone, and said, feel bad. I took 1 or 2 of them. Didn't really like the way they make me feel, but then I had 27 more pills there sitting on my counter. My kids were young there at that point, and they were out of their reach and everything. But if there's a babysitter coming into your home, if there's a niece, nephew who comes into your home, we've heard stories of realtors telling their clients to say, empty your medicine cabinet before you do an open house, because kids would start saying, we want to come with you to the open house. And kids would go into the bathroom and rifle through the medicine cabinet to try to get those medications. So again, keeping track of those. We don't get into it in this presentation, again, simply because of time. DEA has take-back days, which can be super helpful, but also there's other ways to dispose of medications. A lot of pharmacies allow for the safe distribution. There's also a few companies that offer packets where you can put the medication in, the charcoal destroys it, or you can mail it back. So there's a lot of ways to get rid of the medication in your home. We discourage people from just flushing medications, because that can be bad for the environment. Again, there's a lot of ways that you can get medications out of your home.
Very good. So go ahead.
Oh, hi, Kevin. My name is Marsha. I'm a public health nurse in Orange County, and I'm just wondering, your presentation was fantastic. And at the beginning, you shared a couple of videos, one of a family where they suffered a long-term disability of a child due to an overdose, and then a young man who shared his experience with being in recovery. Is there a reason you didn't include a family who'd lost someone to death from an overdose? Is that not well received during presentations? I feel like that's a huge part that might be missing, and just wondering your reasoning for not including that in a presentation like this.
Short answer is no. There's not a reason why we didn't include it. Just again, part of this is just the length of the presentation. I'm always very conscious about the presentation not being too long. We do have some videos. They're a little bit older at this point, but where people who have lost share. And the one that's in my mind right now that I'm very conscious of is a police detective who lost his son. His son had been hiding the pills behind a switch plate in his room. And, this detective who's got the badge around on a chain around his neck says, I'm a detective and I didn't know that this was the place to look. So again, it's just very powerful. I will share one thing about the videos. We are conscious of trying to have videos and also the images in the presentation to reflect diversity. It's something we're working to do better at. But just whenever you're presenting to an audience, the more you can do to make the presentation speak to the audience in whatever way that is going to work best, you would just want to make sure that nothing in the presentation would be a barrier to people receiving the information. So that's the only point I'd want to make there.
And Marcia, you'll see that I posted in the chat, we are starting a virtual online grief group this Saturday. Alan Berkowitz is here in the room. He is leading that group. He has lost his son, and he's been involved working with parents for some time. That will be 9 o'clock this Saturday morning. If anyone wants more information, go to info@tpor.org to register.
Yeah, thank you for that. And that may be something that we seek to collaborate with you on, because that's an issue we're facing as well. We've had a number of we have a number of I'm getting a little bit of feedback.
Yeah, I'm going to work on that. There we go.
But yeah, we have a number, I think it's about 15 or 20% of our parent coaches have lost children. So just, and we are looking to expand our online support community to provide support to parents who have lost a child. So that's something we're working on this year as well. So thank you. Thank you for raising that.
Hi, my name is Vicki, and I'm a peer mentor with a program that provides mental health services for men and women that have been incarcerated. And I did put a comment in the chat, but I'm not sure if this is suitable for this presentation. But a lot of our people come to us on methadone, and they've been given methadone in prison, and they've been given that for pain relief. And we even have a couple of clients that have been prescribed methadone for pain, and they're not incarcerated at this time by their PCP. So I'm curious what the DOJ or what the consensus is regarding methadone for pain, because it's creating a huge problem in their life.
Well, a couple things. And part of this is the first time I've been asked this question directly. So my email is on the next slide, and I will ask if you can email me, and I will connect with our some people in the organization who may be able to answer better than I can. A couple things is, looking at alternative treatments for pain relief to see if there is something out there that could be helpful in lieu of methadone instead of methadone to relieve the pain that they're having. Part of the opioid crisis, we think of it really starting in West Virginia, in New England, et cetera. And part of that was people working in extractive industries, where people were getting injured or people getting hurt. Nobody wanted to pay for physical therapy. The cheapest thing was just to give people pills. And that's what kind of sparked a lot of the opioid crisis that we see now, is just the over-prescribing and prescribing instead of providing people with alternatives that would relieve pain. So the first thing would be looking at alternatives to opioids for pain relief. But the other piece of that is looking to alternatives to methadone in terms of some of the other medication-assisted treatment that is available now, some that has been developed more recently than methadone. Suboxones, I know that there can be some issues with those as well, but some of the other substances that are out there that can be really helpful to for someone who does not want to use opioids anymore, so they can avoid some of that craving, some of the craving, and also some of the withdrawal as well. So again, please shoot me the question. I'll share with some of my colleagues who may be able to answer better. But again, I find that to be those are just some of the thoughts I have based on what I know. Prescribed multiple years. Okay, so question. I'll just read it. Met with a. Okay, Muriel, thank you for asking the question. Medical detox nurse, withdrawal management. Yesterday, I met with a client that is being prescribed multiple years oxycodone and Vicodin. In seeking services, she asked that her prescribing doctor not be alerted to her using. She disclosed sometimes taking 10 to 12 pills a day. She also uses heroin and fentanyl. She seemed to desire help and also not wanting to stop use. A few things on that. The first is, the more you can encourage the step towards wanting to get into recovery, is just encouraging that positive step. As part of parent coaching, there's something we teach the parent coaches that they share with the parents they're working with. That is, ambivalence is normal. Is that for many things in our life where we want to change, but are also uncomfortable making that change, or maybe anything we do in life, there's a reason why we're doing it. If we do it more than once, there's a reason why we continue to do it, whether it's going to work, whether it's some activity that you enjoy, there's a reason why you do things again and again. And when it comes to substances, people are getting something out of the use of them. So there's a reason why they want to continue to use. So this woman, she may not want to feel pain, but also she does not want to go through withdrawal, which makes a lot of sense. I mean, it's horrible that you not want to go through that. But at the same time, she may recognize that she'd be healthier if she were not using. So again, being able to offer some ideas around medication-assisted treatment, some ways to manage withdrawal is important, but just understanding that conflict is normal. Looking at it from the outside, and you working in this field, I'm sure you know this. I'm not telling you anything you don't know here, but for others, people look at someone who's using and say, why can't they just stop? Why don't they just, why don't they just stop using? Well, there's a reason for that. It's both chemical, but also mental and physical, that they're getting something out of the use, and also knowing that stopping using would make them feel horrible. Very few people would want to go through that voluntarily. So it takes a lot of courage for someone to even take that first step to explore options to stop using. Is that making sense? Is that helpful? I see.
Kevin, my name is Merlin, and I'm very interested in the medically assisted recovery and the relative costs, because you mentioned several times the fear of withdrawal. When they talk about methadone for pain relief, my head says pain relief or fear of pain, because methadone has purpose, as you know. But I'm curious to know what kind of effort is being made to not only communicate about medically assisted treatment and or recovery, and costs.
Sure.
Access and costs are two things that are important. Yet for me, it's the answer to reduce craving and reduce this fear of withdrawal is key to recovery. Period.
Yeah. So we obviously have the content available on our website, but what's really important about the helpline, as well as Help and Hope, some of the other resources we talked about, is when we're able to engage in a conversation largely with parents and caregivers, our services are really set up for the family members rather than the person using themselves, is ways to have conversations about medication assisted treatment or medication assisted recovery, trying to provide support and information so that and even the guide itself, the ebook, is, you can speak to it far better than I can. But being able to provide that information so that a parent can have a constructive conversation, but also our helpline and our parent coaches and everyone who's talking to the parent who's trying to help their loved one talks about things like ambivalence is normal, about ambivalence making sense, about some hesitation towards taking another pill, talking to the parent who says, I just want them to stop taking drugs. I don't want them to put any drugs in their system. Why am I going to give them one drug to stop taking another? It doesn't make sense to me. So our helpline specialists and our parent coaches are able to help walk them through that, to help understand that. So that's, in part just trying to help people understand the issue better. The other is that, they're not magic. I mean, if someone is suffering from mental health issues or from trauma, those issues need to be addressed as well. They may need to have some physical issues that need to be addressed as well. So it's can't be just treated in isolation, but can be part of a larger solution. In terms of the access, and I'm not an expert on it, but there are federal laws for the medications that can be given in a doctor's office that limit the number of patients that a doctor can see. There is an entire process that a doctor needs to go through. And for some physicians, it's just not worth it. It's like, I don't want to jump through all this paperwork. There were some efforts in the past year to make that process a little easier. That's being reviewed right now. Hopefully we'll come out to a solution that makes sense, that has the right balance in terms of making it available. The other thing, there's not been too many positives with the pandemic, but one thing is that telemedicine has really expanded. So, you have a person, instead of having to schedule an appointment and, getting someone that has limited transportation, getting across the city, to see their doctor, to get to have even ongoing discussions or mental health support, they're able to get that support via telemedicine. To have that initial discussion with a doctor. Now, obviously, I may still need to go in to get the medication, but again, it's making the whole process a little bit easier. So, yeah, I guess the point I'm trying to make is that our helpline is able to talk to families in a way where it's medication assisted treatment is part of a larger whole that can be helpful to the person.
Thank you very much.
Thank you. How are you defining addiction? Another question, how are you defining addiction? When you talk about SUD being a health issue, it sounds like too little exercise versus an acute disease. I guess my best way of saying it is that, and I apologize if I'm putting this in a way that, putting it poorly, is for a long time, substance use was seen as a moral failing, is seen as something that someone was just doing wrong, and that, again, someone just needed to stop. We see it as a health issue in the same way it is that cancer is a health issue, that other severe diseases are a health issue that someone needs to deal with. So when we say medical issue may be a better term than health issue, but that is the way in which we're looking at it. We're trying to have policymakers look at it as well, is when you're addressing the opioid crisis in the United States, that it's not that it be treated like any other medical issue. There is that we may be facing. For example, with the pandemic, we have, thankfully we have vaccines on the market now, or vaccines not on the market, vaccines which are available now. A lot of work has gone into trying to, relieve pain, suffering, death as a result of that. It's the same thing we're looking at with substance use. We're trying to relieve pain, suffering, and death. That's what I mean when I'm saying health issue. I apologize if I said that poorly. Yeah, so thanks, Marilyn. That is, Merlin, I apologize. Some science of addiction. It is, again, it kind of goes into the length of the presentation and the ways in which different people present. If anyone has ever attended a presentation that folks from NIDA, National Institute on Drug Abuse, have delivered, they're all about the brain scans, and some people really respond to that seeing the effect that substances have on the brain. And just it's more for the length of the presentation that we don't have as much about the science of addiction in this. Some people respond to that very well, and that is something, if you have slides that you want to include. Sometimes I do this training in a church, and sometimes we're in a church, but it's not the Holy Gospel. You can, as long as you're not changing the underlying facts that we're trying to present, you can add information that you think would be helpful to your audience.
So Kevin, are you able to go to the slide that shows your contact information?
Absolutely. Give me
All
one
right.
second.
I know we're going to need to close out here pretty soon, and we've got one
No
other
problem.
slide to share too. So
Great. Yeah, please reach out. I saw that Danella shared a link to be able to give feedback. We always love to get feedback. I will just share, one last thing. I don't know how many of you may be interested in using this presentation to share with others, but my one piece of advice that I'll give is to try to go to what I call pre-gathered groups. So you can definitely say, 7 o'clock town hall, we're going to have a presentation on substance use, y'all come. And you will have some people attend, which is awesome. But if you can go to a pre-scheduled meeting of a PTA, or if there's a lunch and learn series that is at a local employer, or a civic organization like the Rotary or Elks or something like that is having regular meetings, or there's a neighborhood association who's having regular meetings, and you can get on their agenda. Even if you've only got 10 minutes to present and you pick the 5 slides you like best, that can be a really powerful way to get this information out there. So I just wanted to give a little thought on how you can actually use this presentation out in the world. So that's what I got. So I will stop there.
Yeah, I'll piggyback on that and say, if you are not in a place where you have the time or energy to pull that off, you can always lean on the Purpose of Recovery. One of our staff members would be happy to come and share that information at your organization if that's something that would be helpful too. So as always, our workshop series continues next month with another topic. Next month's topic in May will be peer coach overview. What are peer coaches? What do they do? And this is talking primarily about the peer coach who's working directly with someone with a substance use disorder, a mental health condition, or both. However, as Kevin has brought to your attention, parent coaches are a very, very important future that we want to invest in Orange County. So if you are a parent or you know of a parent that has lived this experience, we would love to talk to them and get them set up with that training that's offered through the Partnership to End Addiction. So you can reach out to us at any time at tpoor.org. You can just hold your phone up to the screen and scan that QR code, or take a picture of your screen and go out later to that URL web address to register for this peer coach overview the last Thursday of the month from 12 p.m. to 1:30 p.m. And next month that will be presented by Tracy Lee with the Purpose of Recovery. So are there any more questions for